Good evening, everyone, and welcome. My name is Nitin Sethi. I'm the Chief Medical Officer for the Commission. I would now like to call the meeting of the Medical Advisory Board to order. I'll just introduce everybody in the room. Can you introduce yourself?
Hi, guys. It's Dr. Angela Gagliardi, Assistant Chief Medical Officer.
Anthony Carrari.
Ambika Nair.
Jamie Noble.
I'm Dave Angelillo.
Great. In Albany, we have Dr. Alley, another member of the Medical Advisory Board, but also for staff, we have myself, Tony Giardina, Interim Executive Director, and Jim Leary, our counsel, and J.J. Castriani, our Excelsior Fellow. And from Buffalo, on video, we have Dr. Meschler. Can you hear us, Dr. Meschler?
Yes, I can.
Okay.
And Tony, we have one other guest here. As I had last time, a fourth-year student from Columbia. I have another fourth-year student working with me on concussion projects. Dave Baker is here with us.
Welcome, Dave.
Welcome, Dave.
He's applying into pediatrics.
5, 6. Well, it's great. We have a quorum, Dr. Sethi, and you can go on.
So we have a quorum with 6 MEB members in attendance, and let's start with the agenda. So the second item on the agenda is a review and acceptance of the minutes of the MEB meeting on the 3rd of November 2016. I hope you have had a chance to review the minutes. They were sent forward to you, I think, today. Tony sent it across. Is there a motion to approve the minutes? Any questions, any concerns about the minutes?
Make a motion to accept the minutes as stated from Buffalo, New York.
A second, please.
Motion made by Dr. Meschel, seconded by Dr. Alley.
Okay, so the minutes are approved.
Well, just have a vote.
Approved.
All those in favor say aye.
Aye.
Opposed, nay.
Nay.
Motion
So
approved.
the motion is approved. So the third item on the agenda is the medical position statement with respect to traumatic brain injury. So I believe this was, you had discussed this in the last MEB meeting in November. I'll take a few minutes to kind of address the concerns which were raised by the members of the Medical Advisory Board about this position statement. So we have raised this position statement, and basically what we are trying to achieve is having some protocol for the management of the combatant for whom concern for TBI is raised. And the way we have divided this is, for combatants who we suspect of having TBI and who we feel they warrant immediate medical evacuation to the nearest level 1 trauma center. So these are combatants who will not be neurologically stable, and this situation might arise either when they are in the ring or in the cage, or once the fight is over, right after that. And obviously, this is simple to understand. The goal in these cases will be initial stabilization of the combatant, either in the ring or cage, or in the locker room, or in the post-bout examination area as the situation demands. And then right after that, immediate transport to the ER of the designated level 1 trauma center. And obviously, this will be in accordance with established trauma principles of pre-hospital care. The only thing we have kind of further sort of clarified is that in all such cases, obviously the ringside physician will send the patient to the ER via transport through the on-site ambulance. And then if you look at point number 4, we try to kind of figure out who are these combatants who are neurologically unstable. So anybody who has a GCS score of less than 13 on assessment, if the ringside physician suspects an open or depressed skull fracture, a suspected basal skull fracture, if the combatant has a post-traumatic seizure, if there's a focal neurological deficit on examination, if he has greater than 1 episode of vomiting, then these will be immediately transported to the level 1 trauma center via on-site ambulance. So nothing really changes. This is what we have been doing till now. We are just kind of putting it down on paper. But the point, which is the more important point, is how do you identify the combatants who are neurologically stable right after the fight, and at the time of the post-fight physical, you suspect TBI, you have concerns for TBI just because they have been in a big fight, and a lot of blows have been exchanged. So for them, what we are trying to do is kind of the same thing which we kind of presented to you last time. So all combatants will merit a close post-fight clinical observation. And you obviously do a neuro exam, you'll document the GCS score. And then what you want all ringside physicians to do is to have a careful consideration before a final medical clearance. So we want these fighters to be red flagged. And what the red flag status does is it's communicated to every member of the team, which includes the other ringside physicians, the CMO, the ACMO, the commission officials, the concerned inspector, and the EMS staff at the venue. Now, this combatant who's neurologically stable, but whom we have concern for maybe TBI, right now what is happening with these people is the ringside physician will assess them and then either clear them to go home, or he might say, well, I'll observe you for 5 minutes and come back, or they'll say, I think you need to go to the ER for a CT scan of the head. So there's nothing really like standardized. So what we want to do is we want all these combatants to be closely observed, their neurological status monitored by the ringside physician, and the combatant will not be discharged from the venue. I mean, when you discharge home from the venue, until he's had some amount of medical evaluation, which may include a period of observation. We have not documented what the period will be. It might vary from 5 minutes to 15 minutes. During that period of observation, serial neuro exams, neurological evaluations will be carried out. We want that ringside physician to consult with other physicians on venue and the ACMO or the CMO. And if there's a deterioration in neurological status, then obviously there should be a prompt transport to the level 1 trauma center via on-site ambulance. So the final discharge disposition of these people who have concern for TBI is raised, but who are neurologically stable, will be made on a case-to-case basis. If the decision is made to discharge the combatant home, then we will obviously give them instructions to call 911, go to the nearest hospital, or follow up with the physician if they develop any signs and symptoms of TBI concussion after discharge. We obviously will educate the combatant. We do that right now, the corner staff, on recognizing the early signs and symptoms of possible TBI. The corner staff and family members will be instructed to closely observe the combatant for the next 24 hours and to report to the hospital if any change in the fighter's status is noted. And we are going to be handing out to the combatants and their corner staff a list of all the hospitals in the vicinity, a leaflet which has been translated into multiple languages, which lists the signs and symptoms of TBI, namely headache, blurred vision, double vision, nausea, vomiting, and balance or gait problems. So the whole idea of, let me try to explain to you why we are trying to do this. The idea is to find that, sort of plug that, we don't want that fighter to slip between the one who is stable but then deteriorates. Right now what is happening is they might just be discharged, and then they step out of the venue, they throw up, and they deteriorate. So for just to try to plug, and it's very hard to plug that sort of that fighter, but we want to be having some period observation, serial neuro tests, and then some consultation between the doctors there at the venue. We usually, nowadays, what we are doing is we are having a combination of doctors. We'll have an orthopedic doctor, we'll have a neurologist, we might have an ophthalmologist, we have a primary care medicine doctors. So kind of just having a collective decision-making process before a final disposition.
So I'd like to just bring up 2 points, and I will say that they were informed from my attendance at the UFC fight back in, and I don't want to go into too many specifics, but one thing I noticed was that the UFC brought their own physicians who, in some regards, were more conservative in their approach. And I think there should probably be some sort of acknowledgement that the deference will go to the more conservative practice. If in the chance that, let's say that the medical advisory board, for instance, or the ringside physician appointed by Nysac does not think that the patient should go to the hospital, but the UFC physician, for instance, does, then we would defer to the more conservative plan. This came up because anybody who has a concussion for UFC, as I understand, they're sending their participants to the hospital in an ambulance. So I'm just because it was something that I think we hadn't really gone through in our algorithm of what do you do when there's more than one group of physicians back there. It's not, and for the UFC fights, it's not just the Nysac physicians.
Right. So with the UFC fight, I understand your point. So with the UFC fight, what is happening is at the post-fight discharge area, we have our own Nysac physician looking at them at post-fight and doing a post-fight clearance.
Right.
They usually have a UFC physician. They want one or two of them, so either one of them is there. And what they have is they are looking at our discharge disposition, and they might tag on something more on top of that. That said and done, this has been slightly debated whether they should be even allowed to be there in that area, because we want to do our final discharge disposition, and if UFC wants to do something further after that, that's their call, because to some extent, like you said, there's like two doctors, and they might be, you're right, if I say that I think in my neuro examination, I feel the patient is stable to be discharged home, and he's doing more of preventive medicine, and he says, I want a CT scan of the head. Obviously, that places me in a difficult spot, and I would, like any other person, I'll say, yes, sure, do the CT scan. So we are kind of debating that, whether we really want them in that area also, or whether we do our work, and what they want to do after that, that's their call.
I mean, that's the way it played out. There was one instance where the Nysac physician was more conservative, the one that I observed, but it was generally the case that the UFC physicians were more conservative in sending everybody to the hospital.
Right.
So, I mean, I think just some sort of, clause about deference to the more conservative practice.
And I've had some concerns with that, because the UFC physician is not even examining the fighter. He's just standing behind and, hey, I think he needs a CT scan. I never saw a UFC physician actually examine the fight and say why I need a CT scan or why I need an MRI of the leg. So we've been debating that, and we have kind of leaning towards the fact that maybe they should not be allowed in that area. We make a call. If they want to add something further, they want to write an MRI of the brain, or they want an MRI of the knee, then fine, that's their call.
Right, because technically, they really are just observing until we discharge them from our care. So, the way it should go is we do our assessment, write up our recommendations, prepare a discharge summary, and then now they're released to the UFC. And if the UFC wants to do something different, whether it be more conservative, or not, but anyway, they would need to follow what we would recommend. Then they would make their own call.
So to some extent, like UFC is, in my experience, the last couple of fights has been, they have a fighter who's flying back to Russia. He has some frontal bruising. It's been a tough fight. I'll get a CT scan done before I put him on the flight. Now, obviously, I would not say don't get it done, but I would say probably doesn't need it.
Right.
And we had the same thing happen in the last UFC fight. We had a fighter we sent to the ER, and the ER said she doesn't meet the criteria for a CT scan and discharged her. So obviously there's a little bit of thing where we might have to approach you about that also, because I personally, I'm more leaning towards keeping the UFC out of that area, because it's just creating a little bit of...
Especially if they're not examining. If they're not examining, how do you make a basis of,
I actually did have an experience at the fight in November where I was observing one of the Nysac physicians who instituted a more conservative plan than the UFC physician was going to make. And the UFC physician relented. And actually, I happened to bump into the UFC physician casually last week, the day before the Brooklyn fight, and he remembered the experience. He remembered the exchange. He actually told me the update on what the scans were. So they actually did follow through with our plan for an athlete. So it wasn't like they stood in the way or
they're not standing in the way.
Have you guys reached out to them at all? I mean, do they know like who's in charge, and do they know they're just kind of observing?
Yes.
Everyone's on the same page with that.
Yeah, I think we're kind of developing, like kind of feeling each other out a little bit, kind of get to know each other. I think we're kind of laying out the boundaries better now. But yeah, it's exactly the same problem, which I would not even say a problem, the issue which has come up because there has been and that's not just doesn't apply to a CT scan of the head. We have had leg injuries where somebody said he needs an MRI of the knee, and somebody else says, I don't think so, he needs an MRI of the knee.
Mm-hmm.
So,
Yes, came up with a case of a carotid dissection was suspected.
Right.
Right, and the purpose for them being there is just to maximize and optimize communication rather than to debate what should be done. So again, really, ideally, we make a call, we discharge them, then they could make their own assessment, and if it is more aggressive, then they could, take care of it.
As the protocol, which has the statement which stands the way, it will be that, let's assume our inside physician feels that this fighter was in a war, he suffered a couple of heavy shots to the head.
Right.
He's fine right now. Maybe his bell was rung, but he'll clear up. So we watch them for about 5 to 10 minutes. We repeat the balance error scoring system. We repeat the neuro exam. If they clear up, we talk to each other. If we are comfortable with the discharge, we discharge them home. And my personal experience has been, by the time this clearance happens, they have already been in the venue like about 20, 25 minutes after the fight is over. That's a pretty good amount of time by the time they change, and that's a good time for you to be observing them. And when they are being observed, just to answer another question, there will be an inspector who will be there with them till that boxer or MMA athlete is cleared.
Mm-hmm.
And then rest of the ringside physicians might go back to their job they're doing. And then one of the ringside physicians will come back to clear him. So there'll be an inspector with that fighter, looking after him, making sure nothing changes. We'll be doing serial exams, and then one of us will come back and clear him.
I don't know. Is there any utility, and is it even practical? Like when I was reading this, I was thinking that like in the hospital when you're admitted nowadays, they do a post-discharge phone call, like within 24 hours, or even sometimes after a procedure, like an EGD or something. They'll call you the day after. Is it practical, or even any utility in calling the fighter the day after?
Yeah, that has been very hard for us to do.
Oh,
most of the times what we are able to do is we are able to call the ER and find out what happened, what was the CAT scan, things like that. So we do come to know from the promoter what the final
how they're feeling.
To
call the fighter and say, oh, how are you feeling?
If the fighter is discharged home with his corner, then the corner and the fighter is instructed to closely observe the fighter for the next 24 to 48 hours and to go to the ER if they have any deterioration. The way I wanted to write this, and last time that was the problem with our statement which we presented to you last time, was we clubbed the ones who needed immediate evacuation, who were neurologically unstable, with the ones who were neurologically stable and did not need immediate evacuation. The ones who are neurologically unstable, we know the protocol. It's going to be, that's what the protocol is. It's EMS, they'll straight away go. All we have done in that is we've added some criteria for neurological instability, the GCS score, the basal skull fracture, the post-traumatic vomiting. The one which we wanted to plug was the one who comes off the ring or the cage, is walking, talking, and then suddenly goes down. I think the only thing is you can't have a fixed period of observation. You can't say I'm going to observe him for 1 hour because you just tie everybody down. So, for example, in the last UFC fight, they actually had a green room, just to answer your question, where they said, we will send this fighter to the green room, and the fighter will stay there for 1 hour. And the same thing arose. We said, no, that's not fine. We'll observe him till we feel he's comfortable, we feel he's able to be discharged. And once we discharge him, if you want to put him in your green room for another hour and observe him, that's fine with us. Or we'll make a final discharge disposition and then hand him over to the UFC doctors.
So that's the point, that they're no longer under the state's care,
That's
essentially.
Right. That's
Once they're discharged, it doesn't matter where they are in the facility. They could still be in the facility.
Right.
As long as they're discharged, they're considered no longer
Right.
under state's care.
And the final discharge will occur after the medical clearance. That's the time the commission will pay them and everybody's done. And this kind of thing was written because of the IG's concern in the report from 2013, where that's a walking, talking, and dying, what happens in neurological injuries, like a subdural, epidural happening slowly. It's very hard to plug that walking, talking, dying, but this might to some extent help us in that.
I think the point that's come up just now is, not just about this, about a TBI protocol, but it's something that's come up in the last few meetings. And it seems like we get a collective sense there's something missing about getting some closure on a case, right? I mean, most of us are accustomed to having, M&M rounds, for instance, or just some sort of point of contact with the patient to understand, are our policies actually making sense? I mean, if we have feedback censure, right, on the outcomes of the patient, then we could have a great policy because we think it's a great policy, but not really have any data to support it. So I think that also maps with one of the points in the IG's report. And I talked with Tony about this, when we had our independent meetings, and having some sort of feedback loop for us that would come back and say, in the last year there were 30 times that a player got sent to a hospital. Here were the number of times that something meaningful is identified. Here are the number of times that we missed sending somebody to the hospital where a secondary injury occurred afterwards, or something like this. I think that would be helpful in informing our practices.
And we have, that's a good point. We have started that. So after every fight now, what happens is we kind of identify the case which was sort of intriguing. So I'll give you an example. The last UFC, we had a concern for somebody who might have acute compartment syndrome. And I'm a neurologist. I've not seen so many compartment syndromes. That's the last one I saw was in medicine residency. But, that concern was raised by our Nysac physician. It was followed through. He was immediately sent to the nearest level 1 trauma center. They did the initial workup. They didn't measure the compartment pressures, but the ultrasounds were done, and they said they felt he was comfortable. He left AMA, but he was followed up by the UFC physician, and after 2 days, I did get the report back that there was no compartment syndrome. So there is, I think with UFC, that's kind of the feedback that's come through in a much more organized fashion. With the rest of the things, it kind of comes sometimes from the promoters, sometimes from the ER.
Yeah, I think to that point, though, I don't want to necessarily exclude the UFC physicians because they do serve in as a team physician role, right? I mean, it's having them as part of the feedback loop, I think, is actually a good thing.
Right.
It's not to say that we need to try to figure out who's right in the case, but just really defer to the more conservative policy.
Yeah, I agree.
I was going to say part of the issue too is, the UFC is unique. They have a medical team, but not every promoter brings a doctor or has a team that cares for these fighters. And we're in a unique position in, from a medical perspective because our relationship, sort of starts and ends with the event. And, once we discharge them, our relationship is technically over. I mean, we care, we want to follow up, we want to make sure that they're okay and, find out what happens. For instance, if someone is discharged and they're at the venue or even outside and something happens, we're there. I mean, we're going to act. We're not going to say, oh, sorry, we're going to take care of them to the best of our ability. However, to talk about, like your point, making a phone call. So, okay, yeah, great. Doctors make phone calls all the time. If we did come up with some way to follow up, well, is that part of the scope of our duty? And, if it's not and something happens as a result of that phone call, well then, where's our, where does our duty end and what's our obligation, liability, stuff like that. So there are a lot of legal questions that come into the picture. And that's sort of the unique situation when we talk about ringside medicine because it's not your typical doctor-patient relationship. We're there to perform a certain duty, and once our obligation is over, that's where the relationship
it's an
ends.
ER model,
Yeah, it's the transfer.
I thought this was quite good, and I think if we want to vote to approve it, I think we should.
Good.
Thank you for your suggestions, Dr. Kerr. I followed all your suggestions. They were very good.
Thank you.
I'm not Kerr. He's the Scotsman. I'm Alec.
Oh, okay. Sorry, I'll get to know you in due time. So, is there a motion to approve this?
Motion made.
Second by Dr. Noble seconds it. Motion is approved.
Say that again?
We have to vote on it now.
Oh, we got to vote
We
on
need
that.
to vote.
Sorry, I'm learning this. All right, so we had
Motion by
Dr.
who?
Cureri, yeah, and seconded by Dr. Noble.
Okay, all in favor?
Aye.
Aye.
say aye. All right, all opposed, say nay, and it carries. Next item on the agenda.
So the next item on the agenda is the approval of some proposed changes to medical requirements. Predominantly, we're going to talk about three, basically hematology testing, high-risk combatants, and foreign medical reports.
If I may, I was just going to say that this was actually presented at the last meeting for you guys to think about and take some time to digest it all. And we've revised it slightly, but we did not receive any feedback from any members. So if you guys have any feedback now, please.
I'll briefly go over this in case if you didn't have time to kind of look at it. So as things stand right now, we require a platelet count, a PT, a PDT, INR as a part of the medical clinic.
And just to clarify, these are the requirements for licensure, right? That's in
Right.
order to be licensed by the commission and qualified to fight. So all these requirements need to be met before the fight. We're not talking about after the event at this point.
That's right.
Okay.
That's right. So we need a platelet count, a PT, PDT, INR. And as things stand right now, if the PT is borderline elevated, but the INR is normal, then usually the combatant is medically cleared to compete. If both the PT and INR is elevated, and I mean borderline elevated, then we request the test to be repeated. And if the repeat tests are also elevated, then we ask for hematology clearance, consultation and clearance. So what we really are requesting is that we drop the requirement for PT, PDT, INR and just have a CBC, which includes obviously a platelet count. And the reason for that is that, first of all, in the vast majority of these normal young cohort of athletes, the PD, PDT, INR comes back as normal. And there is really no validity of doing this test. So there's no evidence-based medical data supporting this requirement. So we are requesting that we just request the PT, PDT, INR on a case-by-case basis. And if something is abnormal in that, then obviously we'll work that up further.
Mm-hmm. Questions, concerns?
How often is the CBC abnormal?
Really, I mean, I have not found much of the CBC is usually normal. It's very rare the CBC is abnormal.
A lot of times too, we'll find other abnormalities, like a person might have a elevated white count, maybe post-viral, or
Right.
Slightly anemic, a slightly low hemoglobin, but the hematocrit is normal. Something other than the platelet count has come back.
And usually, Ali, what usually happens is even when we send them for a hematology consultation, the hematologist just says a 4-line note saying, this patient is healthy, no bleeding, no history of bleeding in the family, no bleeding tendencies. This is borderline elevation of PT, INR. I medically clear this boxer to fight. Now, really doesn't really add much to the whole process. It just kind of, I feel, is a sort of redundant.
Yeah, my only question was if you have to test for anything. I mean, if the PTT and INR are normal, we're not getting them, I understand that. But if the CBC is normal as well all the time, or most of the time, which it probably is, I mean, with our outpatient surgery, we don't test anything anymore.
Right. Well,
Right?
No, you're right. The CBC is just checked once. I mean, that's the one-time requirement. We're not doing it every time. So it's a one-time
Okay.
requirement to have it on the file, sir.
So if no questions, we can ask for a motion to approve.
Yeah, is a motion to approve, please?
Motion.
Dr. Noble says yes.
For trustee Talent, part 1.
Oh, this is just for part 1, yeah. This is just for the medical test of coagulation.
Yeah, you can
So
do
let's-
them all. You can vote them all.
Okay. You want to go through the whole three of them?
Let's go through all of
Okay.
them. So the second one is slightly more, I think we have to go into it slightly more in detail, is the medical test requirements for a high-risk combatant. So if you turn the page, a high-risk combatant is one who falls into any one or more of the following categories. Either he or she is 40 years or older. They have had 6 consecutive losses in any manner. And the any manner comes in because we are talking about MMA, so there will be losses by grappling and all these holds. With respect to boxing and MMA, if there are 3 consecutive losses by either TKO or KO, if they've had 1 year of inactivity and 10 losses or more as a professional combatant, then that fighter falls into a high-risk combatant category. And the main concern is, as I see it, is that you need some additional testing to assess the cardiovascular and neurological fitness for these athletes. So we are requesting, apart from an MRI of the brain, an MRA. We are requesting a cardiac evaluation and clearance by a cardiologist, a formal neuropsychological evaluation. This might be done by a neuropsychologist, or we'll accept a computerized testing such as the impact test. And if we have a baseline, which I doubt we'll have baselines, but if we have a baseline, then we can have a notation if there's any deterioration from the baseline. And we may request some additional blood workup, some of the metabolic panels, some lipid profile, things like that. And this kind of has come from the ARP, and the idea is a high-risk combatant should have some additional cardiovascular and neurological workup to make accurate medical decisions regarding medical fitness and clearance to fight. Any comments about this?
Yeah, I had a few actually.
Sure.
So just at the beginning, the 1 year or more of inactivity, I would think we would have to spell it out that's after having had an established career. Somebody who's new to the sport would also be somebody who's had 1 year of inactivity. So I presume this is not for new people. This is for people who have had a career in the past. I think we talked about it last time. I don't remember the upshot of it, but why did we want to get an MRA? I mean, an MRA, this is of the brain. I mean, those are sensitive for things like dural AV fistulas, aneurysms, but those would not be suggested by the history of somebody who loses a lot of fights. And then my third point was about neurocognitive testing. I would anticipate a few problems there. Number one is, how do you handle a non-English speaking person who's getting testing? There are very few tests, no matter whether it's computerized or not, that are available in more than about 5 languages. So we might take a look at what language fighters we're actually handling here. And then the other is, how do you deal with somebody who's illiterate and getting testing? Because almost all of those tests are contingent upon somebody having some basic literacy.
The recommendations, and you can answer, I'm sorry to interrupt, but these are based on the ARP guidelines. So that's basically where we got a lot of the information, because these, Nitin and I are now on the board, but the board sat and came up with the guidelines. A lot of other states actually get an MRA in addition to an MRI from the get-go.
I guess just my question for what diagnostic purpose?
Yeah, I see your point. The way I feel that would be, really, if you don't have an MRI in the recent, we might just err on the side of repeating the MRI, earlier than the 2 year or 1 year requirement.
I have no problem with the MRI.
And the MRI brain will pick up some of those things. As regarding your question about neuropsych testing, I understand that's going to be a little bit of a logical, difficult to get it done. But this has been requested at a time of license to fight. So we'll have some time to say, if you are in a foreign country or a foreign speaker, well, get a neuropsych testing in your country and make sure you send it to us.
Okay.
The idea for the high-risk fighters, as you know, is to identify who of these are cognitively impaired, early signs of CTE,
right,
things like that, as I see it from a neurological point of view. From a cardiological point of view, I think a cardiac evaluation by a cardiologist, and if the cardiologist orders further cardiac testing, like echo or stress test, obviously that will be done.
See, for me, that I was going to bring that up, that I have an issue with that, because I think, honestly, if a patient comes to me, I think it's overkill to send them directly to a cardiologist. I think it's best to send them to an internist first, and if an internist feels there's something that needs cardiac evaluation, then to refer them. Because, I mean, most of the time, if they're 40 plus, it's not an indication to automatically do a stress test in somebody like that, unless they actually have symptoms of chest pain or dyspnea or something.
Into the speaker, the microphone, I can't hear.
Okay, so I was saying that, in terms of a cardiac evaluation, I would probably say the patient should be seen by an internist rather than a cardiologist, and just referred to a cardiologist if they actually identify that they have symptoms. Because, just being over the age of 40, it's not an indication to do a stress test. And for me, I feel like if I saw a patient like this in the office, I would ask them, well, have you been training? What's your exercise tolerance? All of that. And I would end up not sending them for anything. So the thing is, there's no indication for an echo unless their EKG were abnormal and had high voltage or something. You're thinking they have a cardiomyopathy. There's no indication for a stress test unless they're telling you that they have very poor exercise tolerance. And then if they did, why would they be fighting anyway? So I think most of it you can just get from the history. And I think if an internist did the history and then said, oh, this guy has chest pain, or oh, he has an abnormal EKG, then I think it's appropriate to refer to a cardiologist.
So you feel like just a regular medical clearance will suffice?
It's exactly that, yeah. And then referral, if there are high-risk features on, either history or EKG or something.
I mean, is the MRA, was that for a cavernous malformation? Was that the indication? I mean,
cavernous malformation, I think that's the way when I look at the ARP,
you
that was...
that up on an SWI or GRE?
Yeah, that's what I felt, that they tagged an MRA on top of an MRI. I guess that was the reason they were looking at.
Okay. May I have a comment, please?
Sure, go ahead, doctor.
I heard most everything, but I hope I don't repeat some of the things that have been said. I agree with most of the comments. Obviously, the MRA, magnetic resonance angiography, would not be useful without the context of an MRI. In fact, in these high-risk individuals, would also emphasize that an MRI should be done at least with a gradient echo or SWI, which is not a routine sequence in many European countries, and sometimes in the United States. I would recommend an MRI with gradient echo / SWI, because in these individuals they have a high risk for microhemorrhages. I agree that the internist could do the work of a cardiologist. I'm a little bit surprised that neurology was dropped off. I mean, these individuals have high risk concussions, head injuries, so I would even consider that these individuals seen by have a neurological examination performed by a neurologist. Now, an internist can do that, but due to this high-risk combatant, I would consider that a neurologist also see the patient. And the comment about neurocognitive testing, including impact, obviously is very much dependent on the nationality and the linguistics. So I think I agree with those comments, and that's all I have to say.
Any other comments, suggestions?
So where does that leave us with the requirements? That's what I guess I'm kind of.
So I think we'll modify this. We'll add an MRI with SWI and a gradient echo, along with an MRA. We'll have a medical clearance by an internist. We'll have a neurological clearance by a neurologist, and a formal neurocognitive evaluation by a neuropsychologist or impact test.
Now let me ask you, Doc. Can I ask you now? It's not necessarily the way I understand the way this is written. It's not necessarily all of those things for every fighter, right?
Right. So additional.
Just for the high risk ones.
It's just for the high risk, but it says the way I wrote it was that it may or may not be needed, depending upon.
Right. So even within the high risk combatant pool,
right,
the way this is written is that the examining, I guess it would be either you, Dr. Sethi, or Dr. Gagliardi will determine which of these exams or all of them are needed.
Precisely.
Does everyone understand that and agree with it? Okay.
I think that fits in line with the discussion we had at the last meeting of giving the evaluating physician the leeway to determine what does or does not need to be included. So that may statement, I think, is good to keep in there.
Okay.
Thank you.
Then the last point was the foreign medical reports, which.
Yeah, so the foreign medical reports, as you know, we are getting a lot of medical reports from fighters who are overseas. They are frequently in languages other than English. The tests are conducted outside of the United States. We don't have any official policy or procedures regarding these MRIs, these other medical reports. So all we are really recommending is that that we consider this and accept it on a case-by-case basis. I've seen some MRIs where the sequences have been very few and far in between, like just 1 or 2 sequences. And then it's also we say that we recommend that the medical reports and test results be translated into the English language by a certified medical translator. And the cost of this should be borne by the combatant or the promoter. And if possible, if we can have a contact information of the doctor who's like an MRI report or other clearance, medical clearance, that would be great, so we can contact them. And the whole idea is that it should be to make the format easily, interpretable so that we can make a accurate medical decision. Anybody have any questions, concerns about that?
One point I would like to make, if this policy change is accepted, we wanted to select a date when this would take effect, because we do have fighters, submitting their medicals currently, and we have some fights coming up. So if I could propose May 1st of this year as the start date that these would take effect, if they're agreed upon. We have our medical symposium scheduled for April 1st, where we're going to review all of our updates in the recent past, and this would be included if it were to be, and then we would give the fighters and promoters enough time to prepare.
Well, how much lag time would they have, or lead time?
After May 1st, so any new, we would just make an announcement.
But if there's a fight occurring, say, May the 2nd,
yes.
and you're going to notify them on April the 1st?
No. The change would be, it would go into effect for, say, May 1st, if we agree upon that.
I'm just saying, do people have enough? I mean, there are potentially a lot of assessments that need to be done on some of these high-risk combatants. Could it all be done within a 2.5 month period? I think that's reasonable. If they're notified about this on April 1st, as I think was what you said.
No. I mean, they would be notified as soon as we would make the change. Yeah, but I'm saying we have our
It would be effective for events. Would it be effective for events beginning in May? Is that what you're saying?
Right. That's what I was suggesting. May 1st.
Okay, for events beginning in May, which we are not yet working on, but which we'll have plenty of time to work on. Okay.
Maybe we could say June too, but because it's the 6-month mark of the year. But if that sounds better.
I'm just thinking about how much time it takes to get a neuropsychologist appointment. It can be a long time.
That's true. I know that from personal experience.
Yeah.
Absolutely, and it's very expensive. So that's one of the reasons why we kind of said that the expense has to be borne by to some extent by the promoters, and it's And you're right. I think my concern more is the time requirement for getting a neuropsych evaluation. But the high-risk fighters will hopefully be few and far in between, and if you give them a heads up pretty early, might be able to do that.
Yeah, because this would go in the manual, our manual, medical manual, and published, and obviously on the internet and given to fighters, anyone interested in getting a license in New York State. So, what do you guys think? May 1st or June 1st?
I would think a 2 or 3 month lead time would be necessary.
Okay.
From whenever it gets published.
Okay. So we take take a vote.
Yeah. So is there a motion to approve we'll do it separately, for the coags? Change in the policy for the coags?
Motion made.
Motion made by Dr. Cureri, seconded by Dr. Noble. So the motion is carried for coax studies.
I think they have to vote.
Oh, sorry, I keep forgetting. We have to vote. Is there any vote for that, please? Any objections? Okay.
You're gonna do all three. You're gonna do all three at once, then?
Okay, we can do all three at once. That sounds good.
You just did the first one.
Oh, okay.
Okay.
The other two.
Regarding the high-risk combatants, is there a motion to accept this?
Yes.
Dr. Noble,
Second.
seconded by Dr. Cureri. Vote, please.
All in favor, say aye.
Aye.
Opposed, say nay.
Objections. And for the foreign medical reports, motion to approve, please.
Motion made.
Motion made by Dr. Cureri, seconded by Dr. Noble. All in favor?
Aye.
Aye. Any objections?
And date, it will go into effect
Is changed by the
June
discussion
1st.
of this proposal.
Oh, yeah.
June
Okay, just
7th.
can we make one clarification? That the second, for the second proposal, the medical test requirement for high-risk combatants, it's approved as changed
That's right.
at the meeting, right? It's
That's
so,
right.
and we have that documented, correct? So we.
That's
have
right. I do have that.
that? Okay, so it's approved as changed. Very good.
To go into effect June 1st, 2017.
June 1st.
Correct.
Okay, next, we have a couple of items. I'm going to just jump in there with Dr. Sethi. We have to go into executive session to review the application of a new ringside physician and also to discuss the reappointment of the current ringside physicians. So can I have a motion to go into executive session? Anybody?
So moved.
Moved
Dr.
by,
Noble.
I can't see what Dr.
Dr.
Noble.
Noble.
Seconded by Dr. Alley here. All in favor of going into executive session, please say aye.
Aye.
Opposed, nay? Okay, we're going to go into executive session. And for those purposes, you need to first
They
move.
can mute and then
Yeah.
cover. Yeah.
So you need to move the camera away from the table. Like just shift using the remote.
Let me find that.
This? No,
Move it away from the table.
that one.
That's what I'm saying.
So rotate left or right, left or right.
If that doesn't work, they can drape it with a coat.
Or just cover it. You can cover the camera.
Okay, we'll do that.
And then also, and before you do that, just hit mute on your phone. You hit mute on your phone, and we're going to call the.
They could call. We could call. I sent the email with the phone number here to
Okay.
Dr. Sethi and Dr. Gagliardi if they have it, so they
Okay.
can call into this phone.
So Dr. Gagliardi, you'll call us on the telephone.
Does she have it?
Do you have their number?
Do we have their? No, because Matt. I just sent it to Matt. I sent us our number.
Go ahead and call. Go ahead and call us, Angela.
And we can hang up.
And we're going to close the phone line. Okay, and we're back in regular session. Can we have Dr. Meschel, can you hear us? You have us on mute.
I can hear you.
Okay, you were all set. You're good?
Yes,
Okay. We're going to go back into. Can we have a motion to go back into to exit the executive session and go back into regular session? Is there a motion?
I make a motion.
And a second?
Yes.
All in favor of going back into regular session, say aye.
Aye.
Opposed, nay. Okay. Dr. Gagliardi or Dr. Sethi, do you want to review the votes taken in executive session?
Yes, so in the executive session, the following physicians were approved as their reappointment as panel physicians for the New York State Athletic Commission was approved. Dr. Edward Amoris, Dr. John Boscio, Dr. Avery Brown, Dr. Stephen Gelfman, Dr. Alejandro Guerrero, Dr. Victor Kabi, Dr. Michael Lenahan, Dr. Donald Musi, Dr. Lou Rockowitz, Dr. Michael Strauss, Dr. Gerald Verlata, Dr. Rick Weinstein, Dr. Sherry Walken, and Dr. Frederick Turberry was approved to be on the panel as a panel physician for the New York State Athletic Commission. That's a new appointment.
Okay, so those were two separate votes, and they were all approved unanimously. Both votes were unanimous votes. Okay, next item on the agenda. We're going to old business at this point, and
Right.
there are Dr. Sethi can talk about, or Dr. Gagliardi can talk about a couple of these items that were raised at the last meeting on November 4th or November 3rd in 2016. The actual written policies were provided then. There might be some revisions to them, and their updated ones are provided today.
So we have in front of you the policy for NSAID use, and we really need your suggestions and thoughts about what should be our policy for regarding NSAID use. Right now, as things stand, at the time of the pre-fight physical, we asked all the combatants, have you taken any NSAID in the past 1 week? And the usual recommendations are they should not have taken any NSAIDs a week before the fight. And if they have taken any NSAIDs during that time, they're actually they can be disqualified and not permitted to fight. It's kind of arbitrary. There's a lack of evidence-based medicine data to support this current recommendations of not allowing them to fight if they're taking NSAIDs a week before. So, just a little bit of supporting data, how can we make this more kind of evidence-based? Just some thoughts, any suggestions you have, how we can go about kind of refining this a little bit.
Keep in mind, they do sign a drug acknowledgement policy ahead of time, much farther in time away from the event than the week before. And especially when we see them, hours before the event, it's not a surprise to them. But so they should be aware of this. It has happened where between the weigh-in and the fight, they have a headache or some pain and they take something. So what we started doing is Nitin and I will attend the weigh-in and remind them not to take anything overnight, just to ensure that. But still, we really need to justify our recommendations, and based on the evidence-based medicine or lack thereof, it's difficult for us to justify the policy. So we'd like to revise it and come up with something that makes more sense. Last time we discussed this a little bit.
Yeah, we are hoping the surgeons among you might have some recommendations because you hold platelets, antiplatelets before surgery, so maybe something that in that way can guide us. By the way, right now it's just it's on their honor. They may or may not tell us. A lot of times they say no, and they might still be taking it. I'm sorry to interrupt you. Please go ahead.
Sorry, I had asked our chief of anesthesia at a big outpatient surgery center what their policy is, and he said it's 24 hours. They'd like it stopped before, epidurals and things like that, which have a much bigger risk. So they're comfortable doing that with a 24-hour stop. I don't know what the evidence-based is, but they're very conservative people by nature.
A lot of the research is based on, chronic NSAID use, and that's when they recommend the week before. But, some of these guys, they've just taken not even a full dose of, adult dose of an NSAID like Advil or Motrin, and then we're strapped, we really should be stopping fights for one pill, which, doesn't make too much sense. So that's really where we're at, and that's why we need, to better refine our policy.
Well, can I ask you one thing, though? I notice we have, which it is an NSAID, but aspirin. Do you think that should be maybe an exception, like different, longer period of time? Because like it knocks out platelets for like
right.
10%. You get, what is it, if I remember correctly, 10% a day back.
Right.
So it would take you like 10 days to get the full 100%.
Yeah, and so one of the things we thought about was if somebody has taken something or says I took one tablet of aspirin
right.
or ibuprofen, can we do a bleed-in time or something like that? How do you exactly determine what's the risk of bleeding? And really no good answers. I couldn't find anything much out there.
And then considering, as you're saying, different medications have different half-lives. People absorb medications differently. So we don't know, even if it's at a therapeutic level in their blood, unless we do some specialized test. But then again, we consider costs, who pays for it, all of those considerations. So we really need some help coming up with what makes the most sense.
The concern is really that if they get hurt, that they're going to bleed more.
Right.
Right, but still, they're going to get hit.
No, I understand.
But that's the thing. Regardless, it's a combat sport, so they're going to get hit, and they're going to increase their risk for bleed.
Because for us now at NYU, we have a policy, with cardiac stents, because before people were having aspirin and Plavix being held for some time before. And now the policy is really to continue aspirin unless it's like, neurosurgery or something that really is a high risk. So most of the time, usually surgeons are willing to operate on aspirin. I don't know how you guys feel about that.
Depends on the case.
Yeah.
It really depends on, if it's something more urgent like hip fracture surgery, sometimes we won't even delay for that. We'll just operate through aspirin, even Plavix too. But it's very case dependent, For elective stuff, I still, tell people to stop using NSAIDs or aspirin, 7 to 10 days prior to their elective procedure.
Right.
We would like to perhaps ask for volunteers to maybe work with us, maybe come up with like a subgroup, if anyone would be interested in, discussing further, and we could come up with.
We can do a little bit of the work and then come back to you, and one of us.
If you're looking for evidence, there's no evidence that this is. So there's no evidence.
Right.
So if you're just kind of saying this makes sense, and you're doing it in a medical legal sort of way, then, what do other states do? What's the, I would say fall in line with the norm.
I think New York is probably the strictest in this. Other states are really not even ask.
They ask, yeah.
Put it this way, we don't, there's no policies in any professional sports for this.
Right.
So
football, basketball, what have you.
Like in the recent UFC fight, we had one of the fighters who had acute back spasm pain, so he got a couple of Toradol shots. So all those questions then come up: can we give the Toradol shot? When was the last time the Toradol shot was given? Can I give him another one before the fight? And so we are dealing with all of those things, and we're hoping that we have some thoughts about how to go about that in a more systematic manner.
Or maybe make it case by case, just like some other things, because the way the policy reads, no matter, even if they took one pill, no matter what the dose is, if they took it within 7 days before a fight, then we have to, we're liable to stop the fight, disqualify the fight or cancel the fight. And it doesn't really make sense. Do we really need to do that? And that's really the question. So
I think there are kind of three questions here to answer. Number one is, do we try to follow some sort of established pharmacological properties of these drugs, which are really thin when it comes to evidence, aside from perhaps aspirin? Number two is, do we try to align ourselves with conservative practices of our organizations with whom we work, which are often kind of best practices but not necessarily evidence supported, and that maybe just come down to having a blanket policy of a week, right? I think it would look, to some degree, I think there's a vulnerability you begin to introduce if you have a policy that's pretty liberal when introducing one, and somebody has an injury with a complication like a subdural subarachnoid or brain contusion, and they were on an aspirin or NSAID or something like this. I think you would have trouble establishing grounds for why that wasn't recommended to be stopped, even if the data is pretty thin, just because common practice suggests a week worth of withholding.
So you feel the 1 week policy is fine, and we just standardize, we keep it the same.
I mean, you're really trying to limit liability. That's what
Right.
it comes down to.
Sure.
Liability. If something happens, that's so.
If somebody has some sort of complication, intracranial hemorrhage, and they were on diclofenac 3 days before, I think any attorney worth their salt is going to try to make a case that caused it. If it's out of the system for 7 days, then they don't have much ground for it, even if the data is pretty weak pharmacologically.
So it's 7, or would you more go for 10, like you said? I think you raised 2 numbers.
Yeah, I think 7 days, would be fine.
7 days.
You may want to think maybe aspirin maybe should be 10 days. Because there's a lot more evidence, like you said, with whoever said, I don't know who said that about aspirin. There's a lot more data.
I mean, can you suggest alternatives maybe in this and say that acetaminophen is okay?
That's what we do.
Yeah.
No, I
We
mean,
only
if,
Tylenol.
or like, I don't know if you have to write
Well,
it. but,
again, something to think
That's a
about.
good
I
idea.
mean, but we would like to discuss it further before, and then next meeting we can vote on something if we put something together. Anybody willing to
Well,
work
if you
with
want
us?
that,
or-
I'm willing if you want.
Okay, so
Okay.
Dr. Carreri will work with us.
Okay, that sounds good.
So the next one is on the urine testing protocol, TUEs, and performance-enhancing drugs. So you have a little bit of a handout in front of you. I really want to figure out a drug testing policy and kind of standardize it, a policy regarding performance-enhancing drugs and illicit drugs, and finally about therapeutic use exemptions. So as you know, right now we don't allow any therapeutic use exemptions. So we need to think a little bit about that, especially now. I think there was something about a transgender athletes coming in, so we'll have something about that. And then obviously about our drug testing policy, you can see right now all combatants pre-bout urine testing, we do a standard 10-panel urine analysis, and in title fights, we're going to do additional testing, and then obviously USADA might be there and they'll do their testing. So just if you have any thoughts and suggestions about developing our drug testing policy, our rules regarding PEDs and therapeutic use exemptions, and again, we'll work on this and coordinate with one of you and try to develop this further.
If I can have a comment.
Dr. Meschler has a comment.
On the non-performing enhancing substances, I have 2 issues. I think the one that's going to be an issue, if not today, but in the coming years, is that marijuana metabolites are now, medical marijuana is legal in New York State, and recently was approved for chronic pain. So you're taking that may be an issue going forward, and as many may know, that you can have positive marijuana testing even if you're around marijuana smoke with passive inhalation. So I think we have an issue in Buffalo where a professional athlete, football player from the NFL, was barred for 10 games because he was taking medical marijuana prescribed by a physician for his Crohn's disease. That hit the national spotlight, and in fact, many physicians, including myself, supported the fact that he was using it for medical reasons, prescribed by a physician, and even in his home state of Minnesota, which again, it's approved. So this issue about pro athletes and marijuana is going to be a major issue. The NFL is trying to take it on because most football players today smoke marijuana and are not drinking like the old athletes. So if we don't tackle it now, we will have to in the future where marijuana is going to be an issue in regard to testing. So I'll leave it at that. The only mention is barbiturates is that Fioricet, SJ+, Firanol, which is butalbital, which is a short-acting barbiturate, the commonly used medication for some individuals in post-traumatic headaches. I don't prescribe it in my practice, but it is often used in New York State, and the metabolite of that sometimes will be interpreted as a barbiturate. So those are my two comments.
Thank you.
I think my impression of this whole policy is based upon a presentation we had from Dr. Barlotta maybe 2 years ago in this room.
Yeah.
And it was really impressive, the degree of testing that they have for in his program, which was tennis. And it just struck me about how little we do and how ineffectual a program where you're just testing the day before would be. And it's almost to some degree a moot point as to which drugs you want to pick, because most of the drugs somebody could take as little as 3 or 4 days, or stop 3 or 4 days before a fight, and we would never know it. I mean, to some degree, that it seems to me that the program that we have right now is simply a gesture and not really something that has much science behind it. If we want to continue with what we have, then so be it. But I think we have to be content with the idea that there's a very strong chance that some athletes are gaming the system and using performance-enhancing drugs for a long time, or at least have that potential for doing it, and then stop just beforehand.
Part of the problem is, though, that in this kind of arena is that these athletes are coming in sometimes at the weigh-in. They're flying in the day of the weigh-in or something. So you're not going to catch them a week before. You can't. It's not going to happen. So I unfortunately, I agree with you, but unfortunately, I think this is probably the best thing. And making a comment on the marijuana thing, I think maybe, some of these things, barbiturate too, is that you can make it a case-by-case basis. If somebody had migraine headaches and was taking something that had maybe 5 days ago.
Well, that's where the TUEs come in. So the TUEs are basically, so there's no such thing now in the NFL for a TUE for marijuana, but there is for Adderall, there is for, different, drugs. And so you have to submit it in medical documentation and such. What's probably going to come down the road is a TUE for marijuana. So, so I would never take marijuana off the list, but if you really want to liberalize this, you create a TUE where somebody has a therapeutic use exemption that they can apply for. So this day and age, not having TUEs is probably inappropriate. Having a mechanism in place to create TUEs and create your drug panel that has TUEs, and I would propose this wouldn't be a reinvent the wheel thing, is you create the TUE based on what the NCAA does or what professional sports do, and use that as your template to come up with this.
We have reached out to several organizations to try to, guide us and assist us. USADA is one of them. Part of the problem too is when we want to, ally with these programs is the cost. They're just too expensive. The promoters, the fighters, they just can't afford it. So
the thinking was that we just follow USADA standards, and there are, I think, 2 or 3 USADA labs, and I think the advantage of that will be they keep updating the list of things which are performance enhancing drugs. So we are going to be maintain universal standards in that way, but the cost is a big factor.
Right.
Well, there's no cost for a TUE.
No, I'm talking about the performance enhancing drugs which you're talking about.
The program, right, in general.
So, right, but yeah, you're talking different things. So, like, when I was at the University of Missouri, the athletes would get tested in different they would get tested by the university, they'd get tested by the conference, and they'd get tested by the NCAA. Well, the university never tested for, more the testosterone, the metabolites, anabolic steroids, because it was too expensive. But the athletes were never told that. So they got tested, and so when when the NCAA came in and they have deeper pockets, they would test for everything. When the conference would come in, they may test for everything. When the school did it, they didn't necessarily test for everything, but none of the athletes knew. But the only thing that really works is randomized out of competition testing. So if you're really saying, okay, you want to clean this up, then you do drug testing that works. If you say you just don't want people that have an unfair advantage at the time of the bout, then you do what you're doing now. So a lot of this just depends on what your motivation. If your motivation is to clean it up and make it an even playing field for everyone, then the only thing that works is out of competition randomized testing, which is expensive. And then if you just say, okay, we don't want people to be impaired or
So in the recent UFC card, we did post-bout urines randomly on 4 people, and on the title fight, we did post-bout urine, and USADA did the blood test after that. So, but it was a little bit random, and I'm not really sure how much that really helps or doesn't help.
It helps. I mean,
They know you're watching.
yeah. I mean, I think it has the potential to change behavior.
You're talking about before fights, though.
Yeah, he's out of competition.
So the problem there is that
protocols. It just depends on whether if you're really motivated to clean this
I
up,
hear you.
then you think it's a problem. Then you do out of competition and at competition testing.
The problem is then you have to keep track of all these people,
It's
and the
amazing.
guy might not fight for a year, and then he says, "I want to take a fight," and it's 2 months from now, and he hasn't been random tested, and that's most of the fighters,
I think you'd have to have a national policy. You couldn't do it state by
It has
state.
to, exactly, we definitely have to.
Well,
do
And that's
again,
what we
well,
were talking about when
yeah.
the tennis is what the proposal was. As a state commission, I don't think you'd ever make a policy like this because it's really way above this. It's more on a national or international level for the matter is how you're going to do it on a big scale. So, as a state doing this, I'm not sure really what we're trying to accomplish. Now, and with that too, is this whole TUE thing, to me, is really more of a national or international type of umbrella.
Right.
So when it was presented, that's what I commented is, it just doesn't seem like this is even our jurisdiction as a state, as much as, okay, if boxing in general wants to clean. I mean, the NFL doesn't have a policy state by state. They have a league policy.
Right.
The NBA doesn't have a state by state policy. It's,
Right. Well, again, we're trying to refine the state policy for our purposes, and we won't have an answer tonight. But if we're going to work on it, if one of you would
Yeah, we're
help
talking to
us,
a couple of vendors about this
Yeah.
USADA testing, see if we can bring the cost down and just have a more higher level of testing if possible.
I mean, the question is, are you worried about impaired boxers at the time, or are you worried about competitive advantage?
Both,
Two
I
different
believe.
things.
Yeah, right.
One thing's, you can make a case for at the time, pre-bout testing. The other one is, if you're really going to do something, you're going to have to change your policy, but then that becomes a really national problem.
I mean, one possibility would be to come out of this would be to see if we as a medical advisory board could appeal to the national organizations to say, this is something that we're contending with, but we would really need your help. And I would think it would be, whatever boxing governing organizations are, the ones that offer the international belts and so forth, as well as the UFC, to see if they can all get on the same page and offer some sort of policy. But I agree. I think it's just a gesture what we're doing, really.
Okay,
I
thank
think
you.
a lot of these things, it just seems like there needs to be a bit more cohesion with state-to-state
For sure.
organizations
Right.
than
It's
it
lacking.
seems like there
Right.
is.
Right.
That's like a lot of these policies with the non-steroidals we just talked about. Why that isn't more of a overreaching, national recommendation for these policies to be different in Nevada and New York just doesn't really make sense to me.
I understand your point.
Will anyone interested in working on the drug urine policy with us?
Well, we'll work on it and we'll send it out to you. We'll get your suggestions in between. The next thing is a skin lesion policy. And so just the fact that, now we have in MMA, and we are finding some combatants who have a potentially infectious skin lesion. The last MMA we had a fighter who had a rash, and apparently that was thought to be pityriasis rosea, which I Googled was not contagious, but he had a rash all over his body. So we just want to kind of figure in a policy, a procedure in place, and the main thing is that that should be evaluated by a dermatologist, and then the CMO or the ACMO can make a medical fitness to compete. And whole idea is that you should have somebody who is potentially infectious, something fighting there, and the whole ring gets contaminated. Everybody who comes into touch with that fighter gets contaminated, or open herpetic lesion or something like that. So I think that's kind of self-explanatory.
And again, last time we distributed the NCAA, or at least electronically, I sent everybody the NCAA guidelines. But again, it's a little difficult from our perspective because we're making a determination, are you fit to fight? We can't, or it's outside of our duty to actually treat. And what a lot of the NCAA rules, contain are, the person could be treated for a certain number of days depending on the lesion and the diagnosis, and then they...
Yeah, but don't misinterpret that. Those guidelines are if they come to the event with their skin rash and they've got documented treatment, then they're more exempted. So but it's not like they get to go home and treat. It's real time.
Yeah.
It's
I
real
understand.
time.
Right.
So those are more, okay, somebody has a lesion and you can document that you're not infectious by the fact you've been treated. That's where those exemptions are in their guidelines. But they're not like, you go treat and come back. They're real time. They're just like what you guys are doing. They're these wrestling events. You're weighing in the day before you have your skin check, and you're either going to wrestle tomorrow or you're not going to wrestle tomorrow.
Right. Exactly.
So this is more like those people come to it with a rash. You're at ringside. You're concerned. They bring documentation. Yes, I've been on this medicine. I've made this diagnosis, and then they're exempted.
Exactly. So I guess what we need to decide is, would we accept that documentation, and is it appropriate? And would they be deemed fit to fight? We don't have any policy now that we follow. Basically, if they came with something that looks like herpes, even if they had a note or not, they're disqualified, obviously. But, if they did come with a note, then what do we do? And we don't have any policy.
Well,
So.
I've made this suggestion before. I would really work towards just accepting a policy very similar to what the NCAA has.
Okay. Moving on. I think this study was presented to you last time. This is a head trauma study going on.
Dr. Sethi, can I interrupt you
Sure.
for a second? I just
Sure.
I wasn't sure how we concluded the discussion on the skin lesion policy. Are we going to prepare something?
Yeah, we're going to prepare something and come back.
Okay. All right. So
Joseph?
Go ahead, Dr. Michelin.
I'm being called in, so I have to leave. Do we have a quorum if I leave?
Yes. There's no other, but there might be one item of business. Yes, we do.
Okay, thank you. I apologize.
That's quite all right. Thank
Thank
you,
you.
Dr. Michelin.
Thank you.
Okay, so we'll have the staff work on a policy looking at the NCAA guidelines, as Dr.
Right.
Kinderneck had suggested, and we'll come back to the MAB for your advice. Thank you.
So, more last business under the whole business section was this head trauma study which is going on in Cornell, and the whole idea is that we need some suggestions how to really develop the research sort of part of the commission. So, a couple of thoughts will be that we should collaborate with ongoing studies which are going on in New York State, different academic institutions. We can collaborate with them, but then the question is, what should be the extent of our collaboration? Do we promote their studies? Do we actually recruit for their studies? And so this study, by the way, is I think this was presented to you last time by Angela. It's kind of looking at biomarkers for neuroinflammation, and really the one which concerns us is group 3, which is they're looking for positive controls. They're looking at professional boxers, MMA athletes who are suspected of having CTE. So these are guys probably going to be, further in their careers having some symptoms suggestive of CTE, and that's kind of one of the groups they want to enroll. And regarding what the combatant gets from it, they'll all get an MRI, they'll get a PET scan, they'll get a formal neuropsych evaluation. They'll also get they paid $500 if they complete all aspects of the study. And then if you look at the protocol itself, they kind of clearly say that if, for example, during that screening, some incidental findings are found, they're doing an MRI or PET and they find something, then obviously that will be disclosed to the combatant. But further workup of that condition, they'll have to pay for that. So if they need further MRIs, they need to see a neurologist, they need further testing, they'll have to pay for that. So if you look at the point number 6, incidental findings, the PET scans or the MRI scans could show unexpected findings that seem unusual. These findings could suggest that we have accidentally discovered a disease that you didn't know you had. If the situation occurs, we might recommend that you have these findings investigated in collaboration with a physician who's not involved in the study. This could result in anxiety and healthcare costs. These costs are not covered by Cornell and therefore are the sole responsibility of the subject. Obviously, as in any other study, they can withdraw at any point in time. It's IRB approved. I believe there was a concern raised about would the Cornell IRB approve the flyer to be distributed by our commission? So I actually got a memo from them, I can pass it around, which they basically says that the director of the IRB, that the recruitment material is IRB approved and can be distributed by the New York State Athletic Commission. But this is just one example. There are a lot of studies going on in different academic institutions, NYU, Cornell, Columbia, and just need some suggestions how you want us to develop that. How much should our involvement be with these studies?
I will say from my own experience at Columbia, we get approached, it seems like what's weekly now, with somebody who has the next best mousetrap on how to diagnose concussion, right? And, the way that we've handled it has been on a very ad hoc basis between myself and some of the other team physicians and athletic trainers. But it probably would be best served if we had some sort of, subgroup committee that's drawn from our board that, 2 or 3 people, maybe even 4, because it may be the case, like for my example, I have an MRI study. If I wanted to bring it to the board, I'd have to recuse myself, obviously, and you'd want to have an odd number that could vote. But I think it would be reasonable to have some sort of process in place about what are the steps, basically in order to approach the board for accessing the boxers, what are the steps that would be required, what would be expected of the board to do it. I would think the board would simply be an arbiter of the research, whereas to make it clear to the research team that it's still on their dime to make the research happen, that we are not going to be reaching out to boxers themselves. If they want to recruit, that's still their responsibility. But that it would be for us to either approve or deny. And I think the main issues would be, is there any risk, have their, just like when we approve a physician, have the appropriate steps been taken, IRB approval and so forth.
Right. So obviously the studies will be IRB approved by the institution. What do you recommend the steps the commission takes after when we get a study like that? For example, this study, which is obviously IRB approved, and they are really targeting really like controls which are probably retired boxers and MMA athletes, somebody who has CTE as a positive control or may have CTE. So as I see it, if we display this flyer on our website or as you walk into the commission, if we have a board there and the study is displayed, I personally feel that's not a bad thing to do. We are telling the community of certain studies going on, disseminating some knowledge. But certainly I feel I should not be the one being the research coordinator and kind of taking the data down. They can call the research coordinator and see if they want to sign up. Is that comfortable?
I think that's okay. I think the question becomes, what if the investigator wants to send a research assistant to a fight where there are going to be 20 boxers in the room? Is that something that we would condone or not? I don't know. Because the question is going to come up. Can my research assistant come to the fight and recruit them?
Yeah. Personally, I'm probably not comfortable with that.
I mean, it would be.
I think there are issues of confidentiality and that would come into play in that instance. Also, I mean, thinking about from the commission's point of view, if we, I don't think we would have the authority, or should we, to give access to a third party to view, and get involved with an individual's healthcare. I mean, one of the fighters who's under our jurisdiction. So I guess that I think I would draw the line there, at least on that particular question. What do you think, Jim? Do you have any thoughts on it?
Yeah, I agree, and I don't think we're ready to get into that at this point. I think that what's on the table right now for discussion is a very passive mode of what's being called for. Really, is what should our protocol be for advertising in a passive manner, either on our website or in the commission lobby, studies that from clinics or hospitals or things that people want to reach the boxing community or the combative athlete community. And so it seems like we just need a neutral way to do that to avoid any appearance of impropriety or.
I agree. I think for the question about putting up a flyer, I think it's a pretty straightforward discussion to have. But the question is going to come up. I mean, you're going to be approached. Even when Barry was the commissioner, he would bring, he'd say, I was approached by this device company. What do you guys think? And we would just kind of table it each time. But it's going to come up, and having some sort of policy in place, I think, would be smart.
Well, that's something we can develop internally with Jim's help and Dr. Sethi and Dr. Gagliardi's help, and then we can come back to you with a policy. Can we, with a more encompassing policy, do people or are the members of the board comfortable with just with regard to this Cornell study, which is the one before us, are you comfortable with the idea of posting the flyer either in the commission office or on the website? Is there any concern about that?
Well, is there any issue with the fact that they get compensated for it? Like, would that be, I don't know.
Well, the compensation is just to encourage recruitment.
Right. But would there, I don't know, is there any thought of conflict with that?
No, and actually one more thing which is positive about this, I was reading about that for a boxer, and especially mentioned for a boxer or an MMA athlete who's from out of state, they will fly them out here, they'll put them up for a night, they'll pay for that. And they'll do all the tests in one day. I personally feel, I don't know what exactly my concern with this study is, what exactly will that individual boxer get out of it? He probably will get nothing out of it in the sense acutely. It will just be his data which will get tabulated into something. So obviously in a way, he might I'm not sure, and I can ask them whether you are actually going to let the results of the MRI and the PET and the neuropsych testing be released. They may or may not release that data to individual subject, but they do say about the incidental findings.
I mean, I run 2 studies that have MRI involved with them, and basically what the athlete will get, and it should be part of the protocol, I didn't read it that carefully, but they'll get a safety read, basically summarizing the key points. Whenever there's a question of somebody having, there are basically 3 or 4 levels of concern. Level 1 is basically normal MRI. When it becomes anything other than that, I usually request that I look at the images myself, and they have to be drawn off of the research computer onto a CD-ROM where I can look at them directly, and then I make a decision as to how to counsel the patient. But we don't provide the CD-ROM itself to the athlete. What we say is that there was a concern. We talk, this is for non-athlete participants. We tell them about the abnormality, and then if we want to get something for clinical purposes, then we follow. I mean, it has come up in some of the studies I've been involved with where coincidental findings are found, and they're actually artifacts, but it leads to actually a big headache.
Headache and anxiety. That's right. So.
I don't see anything. I thought this protocol was as I would expect. I didn't have much concern about the incentive. It's pretty standard for most studies like this. I think we should probably recommend not or discouraging studies that include something like lumbar puncture, because that could actually interfere with care. MRIs would not. A PET scan would not. Just so long as they're appropriately consented and informed.
Okay.
So every study which comes up, we should run it past the MAB?
Or a subcommittee.
Or a subcommittee of the MAB. That would be. I think that sounds a good idea. I agree. So Tony, we're thinking of having a subcommittee which looks at these studies.
That's fine.
And then based on that, if there are any concerns raised, those are addressed, the studies approved or said we don't want to be a part of this.
Right. We'll have to. Yes, that makes a lot of sense, and we'll develop some guidelines for the subcommittee to follow. So I guess we'll hold off on this particular question then. Is that?
That's right.
Okay, we'll hold off on this until guidelines are established and the subcommittee is able to meet. That was the last item on the agenda. Angelo, did you have anything else?
No, nothing else.
Just that we did send around, in trying to establish a regular schedule of meetings, I sent around a dates so that the board would meet 6 times a year. The next now the dates that I sent out happen to be all Wednesdays, and I noticed when I got responses back from the members, obviously certain days are better than others for different members. So what we could do is we could alternate the days of the meetings. If Wednesdays are better for some and Thursdays are better than others, for others, or Tuesday, what have you. Is there any particular? Does that sound good to people? I mean, I don't know. I mean, the next meeting is set for Wednesday, April 12th. So this meeting was a Thursday. The next meeting would be a Wednesday. Satisfactory to people? If not, if that's okay. I mean, I anticipate that it would be difficult to get the complete board. There are 9 members on the board. It's probably going to be difficult to get everybody to every meeting. We understand that. But if that's okay with you, the next meeting is a Wednesday, April 12th. All right.
Sounds good.
All right. So, if there's no other, is there any other new business to be brought before the MAB? No new business. Then is there a motion to adjourn?
Yes.
Motion by Dr. Alley, seconded by Dr. Kinderneck. All in favor, say aye.
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 Opposed, nay. Thank you.
Thank you.
Thank you, folks.